Hello, I'm Gareth Morgan. I'm Professor of Haematology at the Royal Marsden Hospital in London, England. I'm here at the International Myeloma Workshop, and we've just come out of the session on high-risk myeloma. For me, at least, this was one of the premier sessions at the meeting, and it discussed what I think is the sort of cutting edge of myeloma developments, which is how we link diagnostic strategies with therapeutic strategies aimed at improving the outcome of patients with myeloma. That's a bit of an obscure concept. However, when you think of it, it's clearly very important, because myeloma is not a homogeneous disease, and there are many different types with different clinical outcomes. And so the aim of current treatment should be to place a distinct therapy for a distinct risk group of myeloma. So what we were discussing was, how do you actually define risk in patients with myeloma? And classically it's been done using the ISS strategy. However, that doesn't take account of the biology of the disease, and in order to take the biology into account, there are two technologies that you can use. One is FISH-based technology, where you look at chromosomal abnormalities, or you can do gene expression profiling and come up with a risk signature from that. So if we take the genetic abnormality first, what we discussed was there are probably 4 or 5 distinct genetic lesions that determine the outcome for patients with myeloma and allow us to define an ultra-high risk group. So just to be clear about what that means, what I'm saying is, if you have only one lesion, so like one translocation, like the 414 or 17p minus, another famous lesion, or 1q plus, just as single lesions, that doesn't make patients high risk. They can have a perfectly good and long-term survival. What we were defining was a group of ultra-high risk patients who have more than one abnormality. So if you have 2 of the adverse abnormalities, your outcome is really quite severely affected. If you have 3, that's a very high risk group. And so what the implications for that are is, if you take all of these high-risk abnormalities, you can define a group of patients that will do very well long-term, whereas on the other hand, you can identify this group of very high-risk patients. And so the implications for that are that we should treat these groups differently, or in medical approaches, we should do specific trials for the low-risk patients, because we need years and years of follow-up to see the benefits. Whereas for the high-risk groups, we can do rather smaller studies, and the endpoints for those happen really earlier on. And so what I think will happen over the next years is that we'll see more and more studies that are designed for these different risk groups. Other people in the session talked about defining risk based on these expression profiles, and it seems that there are 70 gene signatures that can define high-risk groups. And I think there was generally a consensus that going forward we need to address the issue of high and very high-risk myeloma, and to initiate specific treatments for those groups. But where I really see the future is not in this risk stratification. The real future is what these next generation sequencing approaches have delivered, which is defining specific mutations to which you target a treatment. And the example of this is BRAF, which was found on this latest papers describing the sequencing of the myeloma genome, that you could actually target with a specific BRAF inhibitor. The other example is 414 myeloma, where in the session it became clear that the MM-set gene, which is deregulated by this translocation, is clearly a specific target for MM-set inhibitors. So in total, I think it was an excellent session. I think there were strong lessons for the doctors and for patients, and the lesson is that going forward there will be very important strides in diagnostic technologies, and coupling a therapeutic to a diagnostic is the cutting edge of where we'll go in the next 5 years.